This is the FM Gold channel of All India Radio. In the program News Analysis now, we bring you a dialogue on Mental Health Care Bill. The participants are Professor Nimesh G. Desai, Director, Institute of Human Behavior and Allied Sciences, and Aarti Dhar of The Hindu.
Dr. Desai, today we discuss a very important issue, which is the Mental Health Care Bill. The bill was tabled in Rajya Sabha yesterday. Now, this is a very progressive bill, as some would say, but some would definitely disagree with some provisions of the bill. I would like you to tell the listeners what are the highlights of this bill.
Any new bill or legislation that's brought forth is decidedly an improvement on the previous one. Now, the issue can only be how progressive is it or how far does it go in the correct direction. One issue. And the second is, in trying to go in the correct direction, are we by any chance making any errors of omission commission or overcorrection? So, as compared to the 1987 Mental Health Act, for sure there are improvements here. There is the progressive outlook, especially in terms of the assertion of human rights of persons with mental illness or any psychosocial disability. What's important to recognize here is one aspect, and quick brief scientific fact. In general, at least 10 to 12% of the general population can be said to be suffering from diagnosable mental disorders or mental illnesses. But not all of them have impairment of judgment or any difficulty in speaking up for themselves or for their rights. The largest group in which is people with common mental disorders, depression, anxiety, phobia, obsession. We'll all easily appreciate that if I have depressive or anxiety episode, I can go to treatment, but nobody can violate my rights because I will object, I'll protest. So it doesn't apply to that large majority. It applies more to the group what was called earlier as psychosis, what's now called as severe mental disorders. For example, schizophrenia, bipolar disorder, delusional disorder, sometimes dementias. Now that fortunately is a very small number and percentage of the human population. I mean, leave out dementia, other major mental disorders is 1 to 2%. Here again, one more important issue is, not everybody suffering from schizophrenia or bipolar disorder will necessarily have the impairment of judgment on a sustained basis. If I have a schizophrenic breakdown or if I go through a bipolar manic or depressive episode, there will be phases after which with treatment I am alright. So it's only a small percentage of people with mental disorders, severe mental disorders who will have disability, where the act becomes operative. So, admittedly, it's applicable to a relatively small percentage of population, and yet it's very critical because of that small percentage, since they cannot fight for themselves, the duty of the society and the government is that much more to have good legislation in place, more importantly, implement it well. And truly, as a citizen with full respect for our republic, we got to say that the trouble in this country and this part of the world is about implementation.
Of the laws.
Yeah. You know, we have great laws.
One highlight of the bill is that it has broadened the definition of mental illnesses, if that's the right word.
Not broadened really, but it's made it more specific. Unfortunately, the 87 Act, for various reasons and compulsions and limitations of that era, when the draft bill occurred in the 60s and 70s, left it very vague, interestingly. It said all those who are in need of treatment. So, indeed, instead of broadening it, this draft bill actually specifies it a little more, which is nice. But I think what it's lacking is it is not talking about, as I mentioned, mentally ill person with disability. Indeed, it can actually serve the purpose counterproductively. On the one hand, a lot of agencies, including we professionals and the government, are keen to destigmatize mental illness and remove the stigma for persons with mental illness and their families. On the other hand, by actually putting all of them under disability, we might actually be increasing the stigma in the society. We need to differentiate between those who suffer from mental illness, get treated, and get back to the society in normal, integrated well, versus those who are with mental illness with persisting disability and need support or some amount of protection. But the fact that this bill, as is the obligation of the Indian state, the UNCRPD 2008, is trying to align itself to the international predominantly convincing model right now at this time of history for the rights of persons with disability and remove some of the old practices that still continued is certainly a positive step.
This has a very new provision of advanced directives. Now, not many people are familiar with it.
I guess even for those of us who claim to be familiar with it or who understand it, it is intellectually a difficult thing to analyze and operationalize, and emotionally for sure it's a lot more difficult, because essentially about life or death or about any physical illness or about mental illness, it gives each one of us, the principle of advance directive outside of this bill in general, gives each one of us as a citizen the locus to issue and register with a legally notified agency directive about what I would like to be done to myself or not done to myself in case of event XYZ. Now here in this bill it is about that if I declare at the age of 25 or 30 and say if I develop schizophrenia, I don't want to be given treatment X. I don't want to be committed to the hospital against my will. I don't want to be given ECDs or I don't want to be given injections. It's nice in many ways in terms of the underlying Western principle of autonomy of individuals. That's what the entire UNCRPD is about. Self-determination by the person. There are groups and subgroups, professionals, lawyers, human rights activists and others, families of persons with mental illness who have huge debates on this. The catch here, it seems, and this must be said evenly without taking any side, the catch is that the provision for advance directive in the Mental Health Care Bill 2010 also provides for that advance directive being suspended through, of course, an arduous legal process. Understandably, some treatment professionals see this as the only ray of light of hope and say, even if a person has said he can't be treated or he shouldn't be treated, I can go through a legal process or the family can go through a legal process and get him treated against his will. The supporters of right to refuse treatment or the human rights activists actually are very dismayed that what's the point of an advance directive provision if it can be suspended at all. So we'll have to wait for some actual practical experience and then be sensible enough to evolve what we can.
Another thing is it bans electric convulsive therapy without anesthesia and restricts psychosurgery.
I think that's great. Unmodified ECT or direct ECT without anesthesia, unfortunately, continued in some parts of government and private sector both. And I must say, by saying that this provision is good, I might not be the most acceptable or popular guy in my own fraternity of psychiatrists. But I think in terms of human rights perspective and the rights of the persons with mental illness, this amongst many other things is only good. I should like to say towards the end that truly, like we said at the start, from 1858 to 1912 to 1987, the three Indian laws that we have had for persons with mental illness, obviously, each one is a progressive step, and I don't think any one of us individually or as a group ought to be taking any final positions about this. All bills and even laws are essentially evolutionary in nature. And so, as we go along, we will evolve better. Many countries in the West actually have revisions or entirely new acts for mental health care every decade. So, we will implement this and we will learn.
Apart from being a rights-based bill, this also focuses more on treatment within the community and households rather than taking people for in-house treatment.
It does for sure, but there is a bit of an issue there. I am in knowledge that the Government of India, especially the Ministry of Health, is already looking at this, but just for the awareness of our listeners and the activist user carer groups, classically the legislation or program should flow from a policy. Fortunately, we have till now not had a mental health policy. Now I believe it's being framed, and the provision, in a sense, not to be cynical, but in a sense, in providing in the law community-based treatment or non-institutional treatment for majority or for most people is very nice. But if you do not have the matching services on the ground or programs, then that provision falls a little flat. And in objectivity, that must be recognized that providing a lot of things on paper in law not matching with implementation mechanism or services or programs on the ground level is a bit of a unfortunate event. One can always say that the law is aspirational, but I can't subscribe to that too much. Law can't be aspirational. A policy document or a visual document can be aspirational. Law has to be grounded in reality of what we have, mostly. And there it seems it's a bit too aspirational, possibly under the compulsion of having to align itself with the UNCRPD.
I think there was a lot of debate over this institutional treatment and non-treatment outside of institution.
For sure, the institutional treatment is never a good idea. I'll give you a small example. The institution where I work in Delhi is the old Shadra Mental Hospital, which is now EVAS. On an average, we see about 900 people in the psychiatry OPD every day. 100 new cases first contact. And we hospitalize only 0.5% of them. So the important fact is, as I'm always keen to get across to the population, is that at a hospital where you get the most severe cases, after being seen elsewhere, at a apex referral institution, so to say, 99 or 99.5% of the people can be treated and are being treated on outpatient basis, being with their families, being in the society, is certainly what is great science news. So institutionalization, long-term or even admission to hospitals is not the rule at all. And the law takes that position, indeed I would say a bit too late. Unfortunately, yes. In many far-flung corners and states of this country, still the same doesn't happen. The admission ends up being the rule. And so in those areas, the law will help in moving the focus from institution to community-based care.
Now that they're talking of community-based care or home-based care, do we have enough manpower and human resource to actually implement it on the ground?
No, we don't. Neither human resource, nor the infrastructure, nor the facilities. But this again, most of our enlightened viewers, or at least many of them will appreciate this, you I'm sure will see this easily on your own. Largest framework of this country's administration and management, the rules of business as it's called, whether we like it or not, and I've had to come to accept this, essentially lays down that for any set of conditions that covers both health illness component, disease component and disability component like mental illnesses do, the treatment will be the responsibility and the purview of the Ministry of Health and its departments in the state. The rehabilitation will be the purview and the responsibility of the, at the national level, Ministry of Social Justice and Empowerment, at the state level, Departments of Social Welfare. So unfortunately, the mentally ill persons living with mental illness related disability fall between these two stools. The Ministry of Social Justice and Empowerment, it must be said regretfully, up until recently paid very little attention to mental illness related disability at all. But now, one must say, there is an entire Department of Disability Affairs and they are beginning to seriously pay attention to both the infrastructure development as well as the human resource development. So it's a matter of time. And of course, the NGO movement is already vibrant in South India and in Bombay and in some parts of North and Northeast. So as the NGO movement grows, the community will hopefully respond to that need alongside the government official systems responding.
It has some provisions for boards and all where these advanced directives have to be registered, and isn't that too complicated?
That's the dilemma of modern 21st century existence, is it not? I certainly as a citizen believe so. That as we systematize our frameworks, legal, ethical implementation frameworks in every field, more and more, unfortunately there is going to be what can be seen as more of bureaucracy or red tape or paperwork.
Exactly.
For the consumers, for the providers, for those who look after all those groups, it is inescapable. Suppose the trick would be in keeping it as simple and accessible to citizens as it can be without violating the basic framework of provisions which are rights-based. But it seems to me it's inescapable.
Normally the trend in India, as we've seen, is a severely mentally ill person is often thrown out of the house for various reasons, property or whatever. So what happens to those people? They need institutional care.
We have at least of late been talking about not just deinstitutionalization and not make the error of closing down all institutions, but reform institutions and bring them to a level where humane care is possible. A prevention of institutionalization is the next goal. But what you hinted at, I must admit, not only one or two or few of us, but some of us at many levels are beginning to realize, and that is the problem of homelessness related to mental illness. There is the larger social, political, economic issue of homelessness. This bill, I think, will push it in the right direction.
Thank you very much.
You were listening to a dialogue on Mental Health Care Bill. The participants were Professor Nimesh G. Desai, Director, Institute of Human Behavior and Allied Sciences,